Well, I guess while we're waiting for questions, I want to ask Dr. Heyne, the last slide that you talked about, not the picture, but the one before that, of course, chemotherapy, usually patients, when they hear about it, that just makes most patients, at least when we bring it up in our first discussion after the multidisciplinary tumor board, you just see them go into this like phase of disappointment and nervousness, etc. I just want to highlight the fact that though there's lots of side effects and lots of things that patients need to be aware of, I mean, we're typically, at least for a good proportion of patients, we're trying to use these modalities as a bridge to transplant. And this is not something we hope that at least the patients who get to us in a timely fashion are able to tolerate these till the point that they can either go to resection or transplantation. But could you perhaps highlight a little bit on a little different topic, which is, clinical trials and navigation? We did not cover that today in our session, but any advice you would give patients and family members, say if their loved one is diagnosed with liver cancer, but it's pretty advanced, what are a few things that they need to be aware of?
I think for clinical trials, probably the biggest disappointment is to realize how healthy you have to be to participate in these. And so our clinical trials generally require people to be able to walk into the room by themselves with very few complaints. The trials are not about you. They're about advancing science and figuring things out. We need patients that don't have heart disease, lung disease, fibrosis, kidney failure. And one of the biggest problems for us is the comorbidities, as we call it, other illnesses that interfere with trying to make an assessment of whether a drug's a good thing or not. So clinical trials are hard to get into. They're also hard to do. You have to get extra box checked. You have to make extra visits. The major motivation in some ways is helping other people, helping the world. But after that, there is a real and genuine hope that it may make a difference for you also. So I think my caution for clinical trials is we have them, we want them, we need them. But by all means, you have to be very aware of what you're getting into and realize how often we're going to say no, because we really need people to be somewhat pristine in order to figure out whether the drug's failing or whether the other illnesses are causing the problem.
Question for Dr. Hancock, and this is a very simple question, but I'm sure a lot of times when we go see your, primary care physician or a specialist, if a CT or MRI is brought up, then there's some myths around it. I think one of the biggest concern I hear from patients, especially when we bring up these surveillance scans, is about the side effects of radiation, just getting a CT or an MRI. Can you please share your thoughts on that?
Sure. So, most of our patients get either ultrasound or MRI screening, neither one of which involves ionizing radiation. So really, there's no implications for MRI or ultrasound. CT does involve ionizing radiation. There are multiple things that we do to decrease the risks, but there is a cumulative risk effect that does occur on patients over many years of receiving that type of modality. Ultimately, the true risk of inducing a future cancer from even high volumes of ionizing radiation that occurs with CT is extraordinarily small. So the ultimate risk is going to be extraordinarily low. That being said, for CT in particular, if you have CT scan multiphasic every 3 months for 20 years, then yeah, there's going to be a cumulative risk there that is going to be real. But for the individual person, that's going to be very small. So while we may see occasional tumors develop in a population, very large population, for the individual, it's going to be small. But again, most of the time we're dealing with MRI, for which there's zero risk.
Yeah. I also would like to highlight that, the ultrasound, which is the recommended modality with alpha fetoprotein, we touched upon this in the morning session. It's not the best option for every patient, especially the ones with, mid-abdominal obesity, patients who have significant fatty liver. We do see patients have small lesions that will be missed on the basic ultrasound. And hence, if your provider, your physician is talking about doing a cross-sectional study, which is what we refer to the CT scans or MRIs, the amount of exposure, radiation exposure, or kidney problems and other things that you look up on the internet, they're completely tolerable and minimal compared to the benefit that you would attain, especially diagnosing tumors at early stage. So it's really important that you know that these are better options, especially for certain select group of patients.
And then
Yes.
I will say, yeah, I do have one patient in particular who did not like to get MRIs because of claustrophobia. And he was very concerned about this cumulative effect of radiation. And so I actually put him in contact with one of our medical physicists. So, we do have people that are experts in this, of course. And we all went through it together and alleviated his fears that the cumulative risk of the radiation exposure that he was getting, even from those multiphasic CTs, was going to be worrisome. So we do see that in patients. They are worried about it. When you ultimately get down into the depths of the data, the risks for the individual are extraordinarily small. I would not, the tumors are much more worrisome than the effects of the radiation.
Yes.
So I appreciate going left to right with the panel from my perspective. And forgive me if I'm oversimplifying, but I see targeted, systemic, and then finally on the right, surgical, resection. So these disciplines, what I struggle with is the targeted attempts to be curative, right? For example, your ablation or your Y90, your goal is to cure, but it isn't necessarily a cure. It is a elimination of a specific area. But the cure beyond that, could it be that you start from the left with a targeted procedure, interventional radiology of sorts, and then you move to systemic as a follow-on versus move to the far right to the surgical procedure? How do you see that continuum?
It's your turn.
Dr. Simon, I guess, can take this one.
If you have a small lesion and you put a probe in the middle of it and you turn the probe on and it burns way bigger than the lesion that you're trying to kill, technically that is cure. Now, if you have viable disease that grows around the side of it, so residual disease, something that you pick up on your 3-month scan or 6-month scan after, that's, it could be because of technical things. It could be, the probe position, but it could also be because you had blood vessels in that area that were maybe making it so that the heat right next to the blood vessel didn't get quite hot enough to kill the tumor in that area. Technically, that's not failure of treatment, like what Dr. Hancock was saying. That's just needing, additional therapy. It didn't make it so that you are now no longer a candidate for either more directed therapies or resection or even transplant. I don't know if that necessarily answered your question, but what I was trying to get at is just because you pick, or just because one pathway is picked for you, it doesn't mean usually that all the other pathways are off the table. Sometimes you can go back and forth between it. Now, obviously, there are cases where, if the tumor is everywhere, then treating one spot doesn't really make sense unless you're doing that one spot therapy for something else, like that tumor in that one area is causing you to bleed or it's pressing up against something, then yes, you should treat that one area, but understand that that's not treatment for cure. That's treatment for palliation, to palliate against whatever symptom you were complaining of. And the overwhelming treatment, I guess, in your case would be any of the systemic therapies that, Dr. Heyne was talking about.
I get philosophical mostly because I'm really old by now, but the cure is a funny word. So if I put you into a complete remission with chemo, resection, radiation, and then I shoot you, you were cured. If it comes back 30 years later with my drugs, I didn't cure you. Which would you rather be? cure is a funny word. I think a great and long life is really our goal.
Thank you so much. So this question is for Dr. Heyne specifically. So um, we're heavily invested, of course, in this disease state, right? And so
With what?
in this disease state, HCC, the role of ctDNA, right, in terms of, because we're talking about the word curative intent, right, and we understand that you can remove the tumor, right, but in your case specifically, the disease that you can't see, that we, are we there yet with ctDNA, or how far do you think? How long do you think it'll take before ctDNA can detect like the cancer when it comes back, even if the patient was cured and then the cancer comes back again? Where are we, I guess, with ctDNA in terms of?
Right now, we hate it. Circulating tumor DNA is incredibly specific, and it's also very sensitive. And so far, we get to have a diagnosis 1 to 2 months before we see anything. How did that help anybody? We don't know what to do with that information. It's not quite fair. We're using it to make judgments on when to give people chemotherapy after we've cut things out. So if we cut out a colon cancer, which is our best evidence, and we see circulating tumor DNA after the resection or before even, then it tells us that chemotherapy after the surgery is going to raise the cure rate. So that's no small thing. So that's the biggest difference it's made. But afterwards, when we've done a transplant, when we've microwave ablated, and we use this in addition to all the other modalities, we invariably find ourselves in this horrible place where the circulating tumor DNA is high. We know it's 98% predictive it's going to come back. We do MRIs, CTs, PET scans. People start to glow in the dark. I know that you just said that doesn't happen. But at that point, everyone's miserable for 2 months until finally it shows up on the CAT scan. So I'm not a big fan of it because we get 2 months of extra worry and nothing was gained. But that's where we are.
Okay. Thank you. Thank you.